Welcome to this lecture on veterinary pharmacology. Today's topic explained by Professor Govind Narayan Purohit is pharmacokinetics. Listen to the lecture carefully and completely. First, understand that pharmacokinetics refers to what the body does to a drug, whereas pharmacodynamics describes what the drug does to the body. So we start with the definition of pharmacokinetics. Pharmacokinetics is the quantitative study of drug movement in, through and out of the body. It studies the processes of absorption, distribution, metabolism and excretion of drugs. Determination of the drug's concentration in blood and urine to decide its fate. Response related to drug concentration at the site of action. 4 pharmacokinetic properties determine the onset, intensity and duration of the drug action: dissolution, absorption, distribution, biotransformation, elimination, excretion. This figure explains the passage of drugs across the biological membranes and how they are absorbed, distributed and eliminated. Now let us discuss each point in some detail. First, we discuss the absorption of drugs. The drug must go into solution in the body water for activity. The body water compartments include the intracellular fluid, ICF, and the extracellular fluid. Drugs must cross the biological membranes to penetrate the body water. The drug absorption is dependent on the cell membrane structure and the mechanism of passage. Membrane properties significantly influence drug absorption, distribution, and elimination. The following properties of the membrane structure affect the passage of drugs: fluid mosaic. Membranes are dynamic, with a fluid lipid bilayer and embedded proteins. Lipid bilayer, composed of phospholipids arranged in 2 layers, creating a hydrophobic barrier. Protein integration. Proteins are embedded within the bilayer, serving various functions: transport, signaling, etc. Selective permeability allows for controlled movement of substances based on size, charge, and lipid solubility. Composition of membrane layer: single layer, multiple layer. Now let's discuss the passage of drugs across the biological membranes. Depending on the chemical properties, drugs may be absorbed by passive diffusion, facilitated diffusion, active transport, and pinocytosis. First, let's talk about passive diffusion. Drugs diffuse across membranes in the direction of their concentration gradient, the most important mechanism for the majority of drugs, rate of transport being proportional to lipid water partition coefficient of drugs. Drugs having perfect lipophilic hydrophilic balance undergoes appropriate diffusion. More lipid-soluble drugs attain higher concentration in the membrane and diffuse quickly. Large surface area and thin membrane favor diffusion, intestine, lungs. The picture makes the process clear. Filtration or diffusion through the aqueous channel. Lipid insoluble drugs can cross the biological membranes by this method if their molecular size is smaller than the diameter of the pores. The majority of cells have very small pores. However, capillaries, except those in brain, have larger pores. Most of drugs, even albumin, can filter through these. The driving force for filtration is the hydrostatic pressure or osmotic difference between the membranes. It is energy independent process. Specialized transport is energy dependent transport. Solute takes the help of a carrier to cross the barrier imposed by the lipid bilayer. The carrier is usually a membrane protein, e.g. enzyme that binds reversibly with the solute molecule. Transport shows relative selectively. The process is saturable, and competitive inhibition is commonly found. Substance permitting transit of ions across membranes is called ionophores. Specialized carrier equals mediated transports are of 2 types: active transport and facilitated transport, both of which are shown in the figures and explained in the text. The driving force in these types of transport is the concentration gradient. The ability to engulf drug particles is called phagocytosis and the absorption of droplets is called pinocytosis. The absorption of immunoglobulin through the gut mucosa of young claves occurs by pinocytosis. pH partition hypothesis says that the amount of drug that exists in unionized form or ionized form is a function of its pKa and pH of the fluid in which it is dissolved. Most drugs are weak organic acids or bases that exist in solution as both non-ionized and ionized forms. The ratio of non-ionized to ionized drug at any pH is calculated by Henderson-Hassel-Balch equation shown here. The routes of drug administration vary from topical applications to oral and other systemic routes. The choice of the route of administration of a drug is governed by the physical and chemical properties of the drug, their absorption rates, the type of therapy needed. This chart shows the route of drug administration, absorption, pattern, advantages, and disadvantages of the different routes of administration of drugs. Drugs administered intravenously enter directly into the systemic circulation and have direct access to the rest of the body, whereas drugs given by mouth first reach the liver and may be metabolized before reaching the rest of the body. The bioavailability of a drug is the fraction of the administered dose reaching the systemic circulation and is explained by the formula shown. The bioequivalence of a drug is comparing pharmacokinetic profiles to establish equivalence of drug products. The distribution of drugs is influenced by the dose, route, lipid solubility, ionization, binding, and blood flow. The plasma protein binding also affects the drug distribution, availability, and elimination. Drug distribution is the reversible transfer of drug between blood and extravascular fluids and tissues, fat, muscle, brain etc. Distribution is not uniform throughout the body because of differences in the perfusion rates. For drugs administered by IV route, absorption is not a factor. Factors affecting drug distribution from plasma to interstitium depends on a. Cardiac output and local blood flow, b. Capillary permeability, tissue volume, c. Degree of binding of drug to plasma and tissue protein, d. Relative lipophilicity of the drug, a. Blood flow varies widely, brain, liver, kidney greater than skeletal muscle greater than adipose tissue, skin, viscera. Example, propofol has a short duration of action post-IV administration. Reason, rapid distribution from the central nervous system to other tissues, high blood flow to CNS plus high lipophilicity. B. Capillary permeability in the liver and spleen. Basement membrane of the capillary is exposed due to discontinuation, through which large plasma proteins can pass. In the brain, the capillary structure is continuous and there are no slit junctions that prevent many substances from entering the brain. Highly lipid-soluble drugs enter the CNS easily, as they dissolve in the endothelial cell membrane. Ionized or polar drugs fail to enter the CNS, cannot pass through the endothelial cells that have no slit junctions. C. Binding of drugs to plasma proteins and tissues. 1. Binding to plasma proteins. Albumin is a major drug-binding protein that acts as a drug reservoir. When the concentration of free drugs decreases due to elimination, the bound drug dissociates from albumin and maintains free drug concentration in plasma. 2. Binding to tissue proteins. Tissue reservoirs prolong the action of drugs or may also cause local drug toxicity. D. Lipophilicity. Lipophilic drugs easily cross most biological membranes. Hydrophilic drugs do not readily cross the membrane. The apparent volume of distribution. It is a ratio of the total amount of drug in the body to the plasma concentration of the drug at time 0. Volume of distribution. Distribution into the water compartment in the body, plasma compartment, extracellular fluid, or cellular site, cells. Redistribution. Highly lipid-soluble drugs get distributed to highly perfused organs, and later less perfused but more bulky tissues like muscle and fat take up the drug. Hence plasma concentration of drugs falls, and the drug is withdrawn from highly perfused organs. And if the site of action of the drug was in highly perfused organs, redistribution results in termination of drug action. Greater the lipid solubility, faster the redistribution. Example, the action of thiopentone is terminated due to redistribution. There are two special barriers that restrict the drug entry: the blood-brain barrier and the placental barrier. Metabolism of drugs, biotransformation. Apart from the liver, metabolism also takes place in blood plasma, the lumen of the gut and other tissues like intestinal mucosa, kidney and lungs. The product of biotransformation is less lipid soluble and more polar in nature, helps in excretion. Mostly hydrophilic drugs are not biotransformed, for example streptomycin and neostigmine. It is divided into two types of reactions, phase 1 and phase 2. Metabolites of phase 1 may be pharmacologically active or inactive, but phase 2 metabolites are mostly inactive. Drugs are eliminated from the body by biotransformation, metabolism, and excretion. The drug metabolism includes the phase 1 reactions including oxidative, reductive, and hydrolytic reactions. The phase 2 reactions include conjugation reactions increasing water solubility. The major route of elimination is renal excretion through the kidneys as shown in the picture. Elimination also occurs through the bile, milk, lungs, saliva and sweat secretion. Kinetics of drug elimination. Three fundamental pharmacokinetic parameters determine the drug elimination: bioavailability, F, volume of distribution, Vd, clearance, Cl. It is the theoretical volume of plasma from the drug is completely removed in a unit of time. First order kinetics. The rate of metabolism and elimination of the drug is directly proportional to the concentration of the free drug. A constant fraction of the drug is metabolized per unit time. Clearance remains constant. The majority of drugs follow FOK. Zero order kinetics. The rate of elimination remains constant irrespective of drug concentration. A constant amount of drug is eliminated in unit time. Cl decreases with an increase in concentration. Few drugs follow ZOK, e.g. ethyl alcohol. Plasma half-life, T1/2. The plasma half-life, T1/2, of a drug is the time taken for its plasma concentration to be reduced to half of its original value. K, elimination rate constant, equals Cl, Vd. First order kinetics T1/2 remains constant. Zero order kinetics T1/2 increases with time. Lastly, we talk about the methods of prolongation of drug action. This can be done by prolonging absorption from the site of action, oral, sustained release tablets, boluses, drug particles coated with resins, parenteral, depot injection for S, C, or I, M, routes, inclusion of vasoconstrictor with drugs, adrenaline with LA, B, by increasing plasma protein binding, use of congeners that are highly bound to plasma protein, sulfadoxine. C. Regarding the rate of metabolism, by small chemical alteration in the molecule without affecting its biological value, but metabolism is markedly affected, addition of ethyl group to estradiol, inhibition of specific enzymes by one drug, phosostigmine prolongs the action of acetylcholine, D, by retarding renal excretion. Tubular secretion of drugs is an active process and, hence can be suppressed by competing substances. Probenecid prolongs the duration of action of penicillin. Thanks for watching. Like, share, subscribe to GNP Sir Classes channel. See you again.